All right. Hi, everyone. Dr. Penny with Low Country Wellness Center. I am honored to introduce you all to my gal, Tina Rose. Tina is a women's health nurse practitioner up in Attleboro, Mass. And she is going to talk to you guys about all things women's health. We've had some questions that were sent in previously, so we'll address those. And then Tina will kind of hit whatever hot topics are big right now in the women's health world. So take it away, Tina.
All right. Well, thank you very much, Penny. It's an honor to be here and share with everybody. My passion happens to be women's health and wellness, and I have been a women's healthcare nurse practitioner for 32 years this year. And it has been my passion to care for women. But in the last 10 years, I've really focused more on holistic integrative health. And that's how Dr. Penny and I connected. And I own my practice here in Attleboro, Justice Women Health Center. And it started out as traditional gynecology, and I do all things gynecology. But I truly believe that women's health is more than just gynecology. I often say to my patients that I am a women's health specialist. And the last I checked, women have more than just uteruses and vaginas. So, when they all interact, I like to take care of their hearts and their skin and their brains and their stomachs, and because everything interacts, and we can't look at the body parts through a tube and only take care of the ovaries and the uterus and not worry about how it impacts the rest of the body, and vice versa, how the rest of the body impacts our ovaries and female hormones through all ages. And I do take care of women from menarche through end of life. So I'm very happy
Full
to be here.
range. So before we get into the questions that were already submitted, any hot topics going on right now in the women's health world?
Bioidentical hormones
Yeah.
is a hot topic. I mean, menopause has always been an issue, if you will. We all go through it at one point or another, and there's many experiences that come with it. And going back, when I first started practicing 32 years ago, it was Premarin. Everybody went on Premarin as soon as they hit menopause. There was no ifs, ands, or buts about it. It's what we did. And Premarin was the #1 prescribed pharmaceutical at that time. And we truly believed theoretically that women who went on estrogen at the time of menopause had stronger hearts and, had less risk of heart disease, and heart disease being the #1 killer of women. We said, okay, people need to go on hormones so we can protect their hearts. So the WHI study came about as a result of that, because they figured we needed the evidence to prove that indeed hormones protected the heart. Well, the study was stopped at 7 years because they found that, it actually didn't help heart disease, may have made it slightly worse. But fast forward another 15 years, and we realized that that was a very poorly designed study, and it only looked at Premarin, which is technically a natural hormone because it comes from pregnant horses, but it is not a bioidentical hormone for us human women.
Right.
Human females. So I always say, not for nothing, I'm not a horse. I don't want a horse's estrogen. So we really made a comeback, I think, with bioidentical hormones because women are living 1/3 of their lives beyond the age of menopause nowadays.
Yeah. Well,
So,
do you have a preferred route that you do? I know in the bioidentical world, route, we talk about delivery system, in our alternate lives. So do you have a preferred delivery system for your bioidenticals?
I customize it based on the woman's preference. I should say I have a non-preferred delivery route. I
Yeah.
prefer not to bring hormones into the GI system
Okay.
because of absorption issues and having to make the first pass through the liver. That's where we might get some of the benefits for cardioprotection. But whether it's a patch through the skin, I do use a lot of creams.
Yeah.
Most women who do come to me for bioidentical hormones are thinking creams. But we do have pills that are technically bioidentical. If you're using estradiol, it's a
Hmm.
bioidentical hormone. If you're using progesterone versus Provera, micronized progesterone, you are getting bioidentical hormones. But again, absorption and bioavailability matter.
So one of the questions I get asked all the time, because I too do a lot in topical, is why do we put it on the thighs? Why can't I put it on my back? Why can't I rub it on my arms? So how do you do that with your gals?
Technically you can. I have a lot of women that will put it on their belly, and if there's not too much belly fat, so that's where, same thing with the thighs. I do have women that'll put it on the inside of their wrists.
Okay.
So everybody's going to be different to where they're going to, and a lot of them rotate it. I work with a couple of local compounding pharmacies, and the pharmacists really will say, it doesn't matter, as long as it's on the skin where it's going to penetrate through the skin. And I say you don't want to put it on areas that are going to be high fat or high muscle, because it's going to have to penetrate
Right.
that other tissue to get to the bloodstream. So I know a lot of people do use the arms. The back is a little difficult.
Well, I have, we've several husband and wives, and they're like, why can't we just rub it on each other's backs? I said, listen, y'all can do anything you want at your home. Nobody's judging here. It's all you.
Yeah.
Another question about bioidentical that comes up a lot in my practice, and maybe yours, is what are your thoughts on pellets?
I have mixed views on them. I I think the delivery route is probably okay. I'm not real comfortable with having to manage the amounts.
Yeah.
And I personally prefer compound pharmacies, and because I do a lot of blood tests, and I will manage. Not everybody needs the testosterone in there. Not some people need more progesterone, our happy well-being hormone. Every time we talk about menopause, all we ever talk about is, oh, I've lost my estrogen and all the estrogen side effects. But we
Right.
start losing our progesterones earlier, much earlier than our estrogens, and we can get side effects from that too. That's where we get the
Mm-hmm.
moodiness and the heavy bleeding, and a lot of things without progesterone. So I may want to start adding in just a progesterone cream before they lose their estrogen, because now they're dealing with all that unopposed estrogen because they don't have enough progesterone.
Right.
So I prefer creams compounding just because it gives me a little bit more control, so I can customize it for the individual, where
Yeah.
pellets seem to have standardized
Yeah.
dosages, and then it's in.
Yep.
And if you're having issues and side effects, I can't go
That's
back
it.
in and take it out.
And I think for me, in what I do, I think that's my biggest issue is I don't want to put things in people that I can't take back out. And then we've just got to ride out the symptoms, waiting 6 months or so for them to feel better.
Exactly. It's
So,
interesting when it comes to contraception. I used to say that years ago, even when Depo-Provera, the shot for 3 months came into, um, everybody loved it, but there were side effects.
yeah,
And if you had side effects and couldn't tolerate them, oh, well,
yeah,
you've got
wait
it
it
for three
out.
months, like it or
Yeah,
not.
yeah, yeah. And I remember, 20 some odd years ago, my GYN back then telling me that the ideal for Depo in particular is 9 months. So if you're having symptoms for 9 months, do 3 months of cycles, 3 months of shot, or 3 cycles of shots, and then we'll revisit at the 9 month mark. And I thought, 9 months?
No, that's a
Are you
baby.
crazy? No, I'm not signing up for that. Thank you,
Yeah,
though.
and that was a very non-user friendly progesterone. Provera
Yeah.
is nasty. It's synthetic, and it does have side effects like weight gain and moodiness and anger. And it's like, are
Oh,
we
yeah.
really going to put that to our teenagers for
Exactly.
3 months and
Yeah.
say, oh, just give it time?
Yeah. Well, that
So,
brings up a great question. So, one of the questions we had was actually from a teenager,
oh,
and she wants to know all things ovarian cysts. So, she had some specific questions. So, I don't know if you want to address her specific questions first, or if you just want to give a little overview of what the ovarian cyst issues are, and then we can see if you kind of answer that in your way.
okay, sure. Ovarian cysts, people will say to me all the time, oh, I have a history of cysts. Well, every single one of us who goes through our menstrual cycles develops cysts. We're born
Hmm.
with cysts. We have cysts in our ovary. They belong there. They're functional cysts. Every time we ovulate, we make an ovarian cyst, and they're called corpus luteal cysts, follicular cysts, or the cysts before the egg is being released, before the follicle. I will compare it to the chicken egg. The egg white is the cyst, the yolk is the follicle.
Okay.
And so once the follicle is released, all that's left is the egg white, and that's there for a reason. It's making progesterone, and progesterone's job is to hold the uterine lining intact to accept the embryo. And so in pregnancy, in early pregnancy, that cyst is very, very important to hold on to the pregnancy and make the progesterone until the placenta forms and takes over. And it's all hormonally regulated. So as soon as our hormones don't get the right signal, that cyst, let's say the egg was not fertilized, that cyst is supposed to get the signal to shrink and go away. And then it stops making progesterone. Therefore the lining's going to shed because there's nothing holding it intact. And occasionally gets the wrong signal and it keeps growing even though the egg was not fertilized. That's when we get larger cysts.
Okay.
And cysts can be simple cysts, and they'll usually go away in 1 or 2 cycles by themselves. They can be hemorrhagic cysts, which is they bleed into each other. And sometimes they can get rather large and they will rupture. And that's when people really talk about, oh, I get cysts. A ruptured ovarian cyst can be very, very painful. In fact, it's one of the leading causes of emergency room visits for appendicitis. Turns out to be right ruptured ovarian cysts.
Yeah, which I can see that.
Yep. If it's on your left side, nobody worries about
Yeah.
Appendicitis. But if it's on the right, people are thinking it's a ruptured appendix. And it's that level of pain because the fluid is bursting all over the place. What differentiates a ruptured cyst from an appendicitis is a fever.
Okay.
So, but the nausea, the pain, it all comes along with it. And it lasts about 24 hours. And I can usually diagnose it on the phone where people said they've just had a discomfort for about a week. And then it got really, really painful. And do we have other people joining us?
We do. We let this open up to everybody so they could come on and ask questions.
Oh, excellent. So, so when the cyst ruptures, that's usually about 24 hours of intense pain. Then it goes back to about another 24, 48 hours of a dull ache while that fluid is being resorbed back into the system.
So her question was, is there anything she can do to get rid of them?
Yes, we prevent ovulation.
Okay.
So any type of hormonal contraception that prevents ovulation is going to reduce cysts. So birth control pills, the NuvaRing, the patch. Of note, the hormonal IUDs increases our risk of cysts because it's progesterone only.
Yeah.
And so we're still making our own estrogen, and estrogen is trying to get that follicle mature to release, but the progesterone is not allowing it to. So all that's left is a cyst.
Gotcha.
So,
that makes sense.
Yeah, there's definitely an increased risk of cysts with the hormonal IUDs.
So kind of following that line, how do you stop them from rupturing?
You don't.
Just happens. Natural progression.
Yes, pretty much. It's always good to get an ultrasound if they're too frequent. We do have polycystic ovaries, and that's a little bit of a misnomer because that's an endocrine condition, and it doesn't always mean there's a lot of cysts in the ovaries.
Right.
And people who get a ruptured cyst once every couple of months, that's not usually polycystic ovaries. We do have more complex cysts that always need to be checked out too. So, we get dermoid cysts that women are actually born with and often never know they have till they have an ultrasound for some unknown reason. And a dermoid cyst is made during embryonic development. And it's filled with teeth and hair and bone chips and
entities. So her last question on ovarian cysts, could it lead to why I'm never on time anymore? Sometimes I'm a week early, sometimes I'm 2 weeks late, but if I'm 2 weeks late, then they always rupture the day my cycle starts.
Interesting. They actually probably rupture right before your cycle starts.
Okay.
Because the cyst is making progesterone, and don't forget, progesterone is holding your uterine lining intact and preventing it from shedding. As soon as your progesterone declines, and that's what causes bleeds with the pills. It's not considered really a period. It's called a withdrawal bleed. As soon as you withdraw from progesterone, there's nothing holding your lining intact, and so therefore it sheds.
Okay.
And it could be anywhere from, depending on a ruptured cyst, you're probably going to shed the lining faster because the progesterone goes from, high to nothing, and
Yeah.
then the lining's going to shed. Whereas a cyst that's just shrinks on its own and goes away is going to take longer to trigger a period.
Sure, which makes sense. All right, we're going to jump focus to scar tissue.
Okay.
Next question says, I had an ectopic pregnancy in 2011 and surgery on my right fallopian tube, and I've been feeling aches and pains in that area for the last on and off about a year. The doc tells me that it's just scar tissue, and that there's really nothing to be done about it. What are your thoughts?
That sound, and this only, okay, so surgery on, was the fallopian tube removed is my first thought, which normally with an ectopic
Yeah,
it is, but we don't know for sure.
right.
If it was a ruptured ectopic, there could be adhesions. Scar tissue 9 years later doesn't sound right to me. It definitely should be evaluated with an ultrasound. Sounds more like it could be cysts, because the
Okay.
ovary is going to be right next to the fallopian tube right there. So even if the fallopian tube is there, or even if it's not there, you're going to get cyclical cysts depending on hormones. So that's a difficult question to answer without getting more of a health history. And
But she did answer it. So her question after that was, would an ultrasound be my next step? And so the
absolutely,
answer is yes, it is.
yes, yes,
All
I would
right.
definitely recommend an ultrasound.
Next question is breast pain. My cycle is due in a few days, and I've had this nagging pain in my left breast that I get worried about. This morning I woke up in pain. Took some Tylenol, put heat to it, and it's all gone. Is this something that I should be concerned about? I'm 41 with no family history of breast cancer.
Okay. So first of all, most people with that develop breast cancer don't have a family history. So that doesn't minimize your risk. You are at risk for breast cancer because you're a woman, and I'm assuming you have breasts.
Yeah.
However, I often tell my patients that breast cancer doesn't hurt. So it's when our breasts are not hurting that we need to be worried about breast cancer, which
Yeah.
is most of the time.
Yeah.
So it sounds like there's probably cystic breast tissue that responds to your hormones, especially if it's before your period. So people think it's more of an estrogen effect, but estrogen is more dominant at the beginning part of our cycle. This is another case where I would really want to get a good health history and find out what caffeine intake is like, or what
Sure.
chocolate might be like premenstrually. If it's only in one breast, I would say, when was your last mammogram? You might have a large cyst, because typically we're going to get breast tenderness premenstrually in both breasts. It's going to be bilateral. And anything that's bilateral, we really don't need to worry about. The fact that it's unilateral, do your good breast self-exam, go see
Right.
Dr. Penni and get a breast exam and make sure, see if you need to get an ultrasound or a
Perfect.
mammogram.
All right. Next question is, talk about the changes in the cervical cancer screening guidelines.
They've been changing, and they keep on changing, and I've been around for all of them. I started doing pap smears when it was the little slides, when you had to smear it and spray it with hairspray, is what we used. And gosh, we started pap smears early on in life, and we had to have them right up until we died every year. So the guidelines started with the Bethesda system years ago, when they started classifying them differently. And then with the advent of HPV testing, it's really changed. And to see where it's going is interesting. So, 15 years ago, I used to do a lot of colposcopies. Now I do 1 or 2 a month. And that's the way we evaluate an abnormal pap smear. So the guidelines right now are saying that we don't start pap smears till you're 21. Regardless of sexual activity, there's no need to do a pap smear. I'm on board with that. I really agree with that guideline. I've seen the research and the evidence. We can go every 3 years in women under 30. I personally, in my practice, will do every 2 years in women under 30, because we just don't know when they're going to come back. And if I wait 3 years and then it's 5 years before they come back, I've seen theoretically and in practice, I've seen too many pap smears that have gone from normal to a high grade lesion in 2 years. So I prefer not to go 3 years in that population.
Okay.
And then once they're 30, The guidelines say we can go every 5 years if we do co-testing with HPV. I refuse to go 5 years.
Yeah, I
You know,
agree.
the evidence is there, and there is, you know, I looked at all the research when it went to 3 years, and that was about, oh, close to 15 years. Time flies. That they went to every 3-year testing with the pap smears with co-testing. And when I looked at the research with lots and lots of women, the studies were pretty clear that your risk of developing cervical cancer in 3 years, if you've had a negative pap smear and negative HPV, is really close to zero. So if there's zero risk, I feel totally comfortable. Even if the day after I do your pap smear, you go out and get new HPV, high risk HPV, in 3 years, you're going to have an abnormal pap smear, but it's not going to be cervical cancer.
Mm-hmm.
So if somebody is in an area of the country like we are in, you know, where we have access to healthcare, I do feel comfortable with 3 years. You know, we've got to look at, you know, women in rural America even
Right.
that just don't have access. And so in that case, you would do it whenever the woman is in. But I do go every 3 years. The research for 5 years is good. Your risk is low, but it's not zero.
Right.
So it's such an easy test. There is some indication right now also, the future of cervical cancer screening may be going to HPV testing with reflex to pap smear. If HPV is negative, we don't need to do a pap
Why
smear
bother? Right.
because it's
Sure.
looking at the DNA of the HPV and only the high risk HPV types.
Right.
And if the HPV is positive, then we would go to pap smear to see, is it causing any changes in the cells of the cervix? And if so, then we go to colposcopy to see, is it, yeah, these changes invading into the tissue of the cervix.
Sure. Perfectly makes sense. All right. Next question is pelvic exam after hysterectomy. Why do we need them?
Um, Several reasons, and I have, it depends, and there's different, there are different schools of thought, but also we have to know what the reason for the hysterectomy was and what type of a hysterectomy it was. So people, many women are under the misconception that if they take out the uterus and the cervix, the entire uterus, that is a partial, but they leave the ovaries. People think that's a partial hysterectomy.
Right. Yes.
But that is a total hysterectomy.
Yes.
Because
Yeah.
the ovaries are still in. So
Yep.
that's one reason to still do pelvic exams, because the ovaries are still there. But then there are women who have had the total hysterectomy and the bilateral salpingo-oophorectomy, the BSO, and they'll tell me all the time, they'll come in and say, oh, but I don't have anything left. Why do I need to come in? And I look at them, I said, oh, they took your vagina too?
I love it.
And I say, well, that's part of your women's health, because we do get the
Right.
menopausal changes. There are, you know, we have to look at why they did the hysterectomy. Was there any cervical neoplasia there? Was that the reason for the hysterectomy? Then we need to do pap smears of the vaginal cuff for up to 20 years. You know, women, oftentimes women only see their gynecologist.
Right.
So if I tell them they don't need to have a pap smear anymore, they may think they never have to come in anymore. But I say,
Right.
look, you've got breasts, you've got skin. So that's why I really promote myself as a holistic women's health specialist. So I take
Right.
care of the entire woman. And, you know, I may choose not to do a pelvic exam in some women, but oftentimes with menopause, we get the autoimmune conditions like the lichen sclerosis
Mm-hmm.
that we would never know if we don't go down there.
Sure. Well, and I think perhaps there's a misconception among people. As a women's health NP, you're trained to treat the entire woman. So you're managing other chronic conditions just besides gynecological things.
Yeah, it becomes very difficult nowadays, and part of it is, you know, I'm because I've been in practice for so long. Back in the day, women didn't have to have two doctors, you know, and I
Yeah.
tell my patients this all the time. I says, why do men only have to have a primary care, but women are supposed to have a primary care and a women's health care specialist? And I do a complete physical when they come in for an annual exam. I do a top to bottom physical, much more thorough than often their primary cares are. And I'm
Mm-hmm.
doing more blood work because I'm looking holistically, and I'm really trying to help them reach their optimal wellness. Just because they don't have any conditions today doesn't mean they're healthy,
Right.
diagnoses. And so very often I'm getting women to say, you know what, I'm not going to see my primary care. I've already had my physical. I will be monitoring your blood pressure. I will refill your prescriptions if need be. I'm also going to help you come off prescriptions that you might not need.
Right.
And so a lot of my patients are starting to do that and saying, you're right. Why do I need two providers? And, I remember in my day, we went right from our pediatrician directly to our gynecologist. And when I first started working with a OBGYN, we took care of women's entire health. If their blood pressure was high, we put them on a blood pressure medication. If they had a cardiac condition, we sent them to a cardiologist. If there was a mole that looked suspicious, we sent them to a dermatologist, or we biopsied it right there in the office. We sent them to the specialists, but we were the primary care. But I tell them too, there's no specialty in med school primary care.
Right. True.
And
very true.
and primary care was created by managed care years ago so that they could be the gatekeepers and decide where the healthcare dollars were going to be spent. And that's why they're often not doing full panel of blood work. I cannot tell you how few primary cares in my area are doing any vitamin D testing.
Oh, same. Don't even get me started on
Don't
their,
even get me started.
their thyroid panel of a TSH.
Yeah, reflex to T4.
Thank you for nothing.
Yeah.
All right, another question we have. What are your thoughts on...
Can you get the dog? Sorry.
No worries. The safety of HPV vaccines for teenagers, girls and boys.
I personally believe they're very safe. My daughter was one of the first ones to get it when they came into my practice. When she was 15 is when it was released. I worked with one of the leading investigators actually in the trials. He was an oncology GYN onc in Boston. And his wife was a nurse practitioner, women's health nurse practitioner. We had all worked together. And so when I look at the research and the studies, it was very, very similar. The HPV vaccine is very, very similar to the hepatitis B vaccine. Almost identical, with dead virus. And it wasn't until we started giving out millions of doses that we saw any side effects at all. So it is extremely rare. I think about, how many colposcopies I used to do and how many abnormal pap smears and the trauma that we put these people through. I was very upset when it was only the women and the young girls getting the vaccine before they approved it for the men. And many of the male pediatricians were saying when it was approved, no, you don't need this because you're not going to get any benefit from it. And the only benefit was protecting women. But once we started seeing more of the oral cancers and the esophageal cancers, and now we're realizing that we really, if we're going to, prevent the spread, it doesn't make sense. Just like when I first became a nurse, only healthcare providers and high-risk populations got the hepatitis B vaccine. And then my daughter had to get the hepatitis vaccine before she could go into middle school. So she was 12 or 11 or 12 before she got it. And then my son got his hepatitis B vaccine in the hospital before we left.
The evolution of it.
So, and I think the human papillomavirus vaccine is going to be the same thing. I think it is an individual choice. I do have a lot of moms that don't want their teenagers to get it. Then they come back to me when they're 18 or 20 and they go get it on their own. So, I think it's important that we educate, that we listen. I'm certainly not going to tell somebody they have to get it or they should. I'm going to answer their questions and their concerns and help them make an educated decision. But I look at, the trauma that young girls used to go through with LEAP procedures before they were 20 years old, and and how's that going to affect future fertility.
Well, and I think one of the things that I talk about with my patients is, especially those that have boys, we really always think that we're protecting the girls, and you kind of hit on this about the the oral cancer component to it. And, and I tell my parents, you can live in a bubble and not think that your son is going to do that, but he's going to grow up, and let's protect him now so that he's not passing that on to maybe his future wife or something.
Yep.
There are certainly people in all walks that, immunologically can't handle vaccines, but if they can handle it, then why wouldn't we do it? If we can prevent a cancer, why would we not prevent a cancer?
And that's the idea. I mean, this is a cancer. There are so few cancers that are really preventable. Well, lifestyle, but
Right.
but we look back, and I tell my moms too. This is not, cervical cancer is not. It is a sexually transmitted cancer, but it is not a cancer of the promiscuous. And I go back to the studies in the 1940s, and if we look in the 1940s, before George Papanicolaou came up with the Pap smear, it was because cervical cancer was the #1 killer of women back then. And I tell them, when were women in the 40s having sex? On their wedding nights.
Yeah.
And they did a study that showed that women whose husbands' first wives died of cervical cancer had 3 times increased risk of developing cervical cancer. These two women had nothing in common except they shared the same penis.
Right. Yeah.
So,
yeah. And there's definitely a link. Well, and talk for just a brief minute about the change in the guidelines for HPV dosing now. Now we give the vaccine later because they've expanded the guideline for it.
Yes. And so, in fact, Dr. Michael Steller, who I had worked with, who was one of the lead investigators, we had always used it off-label for women who had high-grade lesions, or who post-LEAP, their margins weren't clear. So we've definitely used it off-label. So the studies were ongoing, which is great. So there is definitely evidence that it can reverse a high-grade lesion. By fighting off the virus. It boosts your immune system to fight off the virus that's causing the lesion. Okay, and so that's wonderful. And the same thing at the younger age group too, where I will always educate the parents that the reason they approved it at age 9 is not because they think women are going to go off and have, these young girls are going to start having sex at 10. It's because their immunity is so strong.
Yeah.
So look at these adults who are getting the MMR vaccine as adults. They don't have lifetime immunity. They need to get a booster. And
exactly.
So if we're giving the vaccine at a younger age, we know our immune system is still growing and thriving, that we're going to have a longer immunity. We may have lifetime immunity. But now the studies were only done till up to age 27. So that's why they stopped it then. But then when we were using it off label, they were actually doing more studies ongoing. So now it is approved. I haven't seen, do you know what age it's approved up to, or is it on?
I want to say for gals, I think it just changed last year to 45, was it?
I thought it was 40s. Yeah.
Yeah.
Yep.
Yeah, because I had a 44-year-old come in and ask me for it, and I said, heck yeah, absolutely.
Yeah.
But why
and
not?
Like I said, when I was in the GYN practice, we actually gave it to, we didn't force it. We offered it, and we said, one of the ways we can treat this, in addition to doing the LEAP, or cryo's really lost a lot of favor because cryo doesn't give us any tissue to send to pathology to see, did we get it all?
Confirm. Right.
Yeah.
You're just taking a blind leap of faith. Well, those are all of our questions.
Yay.
Any other things that you think our folks need to hear about when it comes to women's health? I know this is Cervical Cancer Awareness Month. We kind of really just hit on that. So any other words of wisdom?
And cervical cancer, I have always said there's really no excuse for it because, except for people that don't have access to healthcare. And, I'm in Massachusetts here, where, we had the Affordable Care Act, or we had mandated insurance coverage well before the rest of the country. And I said, but deductibles are so high. So oftentimes, and people won't get an ultrasound screening sometimes that I recommend because they can't afford the deductible. But with Pap screening, it's all going to be covered. So that, and it's a very, very cheap test nowadays. So I think we can pretty much eradicate cervical cancer. We're certainly not going to eradicate cervical intraepithelial neoplasia, but we can watch that and we can treat it should it progress. If it's on a continuum. And 95% of all cervical abnormal pap smears are going to regress all by themselves.
Interesting. I didn't know
Yeah,
that.
95% will regress. So we really want to catch. That's why we're not treating, if a young girl under 25 comes in with a low-grade pap smear, we're not even doing a colposcopy. We're repeating in a year.
Okay.
You know,
Interesting.
and only if we catch it progressing to, high-grade lesion do we need to look into it with the leap. If somebody's in their 40s and they've had normal pap smears and they suddenly come back with the low grade, we're going to look into it more quickly because what changed that, or even if they've just had HPV positive 2 years in a row. And that's where the guidelines are going to come in too. And I tell my patients too, these are just guidelines. We've got to really
Right.
get the clinician's expertise in there too. And evidence-based is one thing, but we've also got to treat the individual.
All right.
So,
We've had 2 more questions come in, and then I think we'll wind it down for tonight.
okay.
One is, what is your opinion on starting birth control? Should we give it to the young gals or no? And then the second question is, what age do you recommend starting PAPs?
Okay, so I'll answer the second question first because we're on pap smears and it's easy. 21. No need for a pap smear on anybody under 21 for any reason. Does not matter when they begin sexual activity, just because their immune system is still going to fight off. And even if, one of the things we were doing before is we would start doing PAPs right after they became sexually active, and they would inevitably have a low-grade lesion because their body is just getting exposed to the HPV and they're trying to clear it. And I often compare the HPV virus to the cold virus. It's a transient virus. And, just because you get exposed to the cold virus doesn't mean you're going to get a cold. Depends on your immunity.
Right.
And even if you do get a cold, it doesn't mean it's going to lead to the disease of pneumonia.
Right.
And so if you have an abnormal pap smear, it doesn't mean it's going to progress to cancer. So, we don't need to do it before
analogy
21.
to use.
Yeah.
That's...
And I will use my judgment if I have a woman coming in that's never had any sexual activity and hasn't started intercourse, and she's 22 and doesn't want to have a pap smear yet, I give her that option. By 24, I'm usually convincing them that they should get one, and we'll do it. And as for birth control, yes, I'm a firm believer in contraception. I don't call for my I have, like I say, even 13-year-olds that come in that need cycle control, and I call the combination oral contraceptives, I don't call them OCPs, I call them cycle control pills. Especially with the moms, because oftentimes these young girls need cycle control, especially when they're more active now and they've got sports and they're at studies. If they're having horrible periods, and I've had young girls that come to me that, have bled through everything at school and are embarrassed. And, I do like my young patients to have had at least 1 year of cycles to get to know what their cycles are going to be like before I start them on something. I'm very individual, where I will talk to the person. Some people can handle the route through the GI system absolutely okay. I do tend to use a little bit of a higher dose of estrogen for my real young girls because they're estrogen dominant, and we need to suppress their estrogen. So I'm not crazy about some of the really low dose pills for them. But they have a lot of options now. I do use IUDs in young teens if they're sexually active and want a real good method of contraception. I do put in the implants in the arm. Those are progesterone only. They don't have any estrogen side effects. So anybody with a family history of DVTs or blood clots really needs to be tested before we give them any estrogen. And a good option for them might be either the progestin only pills or the Nexplanon implant or an IUD.
Perfect. All right. I think you have answered all of the questions.
Yay, this was fun.
So I thank you all for participating and for shooting us your questions. I will post this video to the Facebook page, and then you are more than welcome, of course, to please share it on yours. And if any other questions come in, I will forward them to you. Thank you all, and have a great evening.
Thank you, Penny.
Thanks. Bye-bye.
Bye-bye, everybody.